Hello, everyone. I'm Dr. Irfan Dönmez from Istanbul University, Istanbul Faculty of Medicine, Department of Urology, Division of Pediatric Urology. I'm a urologist and a pediatric urologist who is also doing a PhD on pediatric renal transplantation currently. In our institution, we do both adult and pediatric renal transplantations, and I'm going to give you a brief information on how we approach, as well as in conjunction with some of the literature. Uh, Istanbul University has been established back in the 15th century when Istanbul was conquered, and our Faculty of Medicine has been established in 1827. So lower urinary tract dysfunction, as we all know, may end up with end-stage renal disease, and those patients might require renal transplantation. In more detail, congenital anomalies of kidney and urinary tract might end up with the 30% of the population who needs renal transplantation in the pediatric group, and it is more frequent in developing and underdeveloped countries. And the lower urinary tract has been the correction or uncorrection of the lower urinary tract dysfunction in these has been shown to have a role in graft loss. So the assessment should always be individualized, and we can assess the lower urinary tract dysfunction as non-existing, pre-existing, or indeterminate. So I'll get a brief look on the three aspects. So for no pre-existing lower urinary tract dysfunction, these are generally glomerulonephritis patients who have no underlying problems with the lower urinary tract. So roughly, you don't need so much preoperative evaluation in terms of lower urinary tract in this cases. So a urinary ultrasound regarding to and understand if there's a hydro or hydroureter nephrosis, some sort of bladder anomalies like ureterocele or bladder wall thickening, as well as post-mictional residual volume. So if your history taking or anamnesis does not reflect any sort of lower urinary tract dysfunction, you don't have to go with the dysfunctional voiding symptom scores or voiding diets. But if you encounter, or if there's any sort of problems that you think might be problematic, then you need to do this type of evaluations. In terms of uroflowmetry, if the patient does not have any sort of lower urinary tract dysfunction preoperatively, like in his or her course of disease, we don't need to do a lower uroflowmetry. But if there is a history of overactive bladder or some sort of voiding dysfunction, which we call lower urinary tract dysfunction now, we can go for uroflowmetry. So there are some cases who are indeterminate, such as patients who are under hemodialysis for a long time, who does not have urine, and whose bladder function we cannot assess. Some patients might have undergone bilateral nephrectomy and might not be producing urine, and also in some cases with bilateral renal agenesis, we might not be able to assess the bladder functions. However, these are most likely be non-problematic if the anatomical or functional structure of the lower urinary tract is intact. In these cases, you need to make a careful physical examination, not to oversee some of the pathological features that I'm going to show you in a minute. And also, in these cases, please keep an eye on until the lower urinary tract function has been shown safe after renal transplantation. So those patients, anatomical features might be kept in mind, just to make a thorough examination before renal transplantation in terms of sacral dimples or labial adhesions. So one of the main issues on this subject is if there's a pre-existing lower urinary tract dysfunction. So the aim is to obtain a normal acting lower urinary tract, no VUR, a normal urethra, and no increased risk of UTI. So in order to achieve the lower urinary tract, normal urinary tract, we need to know what a normal urinary tract is. So the bladder should maintain a normal capacity for each bladder, and it should be keeping the urine in its low pressure. So we need to see the compliance of the bladder is within normal limits. and the bladder should void the urine with normal pressures and normal sphincteric muscular activity. So no sort of sphincter dyssynergia or dysfunctional voiding, in which the ST is called when there's a neurogenic problem. And also the bladder should completely or near complete empty, either spontaneously by double voiding or CIC. So in patients who are going to be going under renal transplantation with pre-existing lower urinary tract dysfunction, current bladder status should be evaluated. First of all, you need to do a recent urinary ultrasonography, which would like to see hydroureter nephrosis, bladder anomalies, and post-micturition residual volume. If you are not sure about the anatomical situation, you can always go with an MR urography. So this patient should definitely go with dysfunctional voiding symptom scoring, voiding diaries, uroflowmetry, possibly with EMG activity, which will show any sort of problems with the sphincteric activity, which although indirectly. And if we are unsure, then we should go with further urodynamic studies. So urodynamic studies are, they are called urodynamic studies, but under the caption, there are some sort of different approaches, which are uroflowmetry, cystometry, pressure flow story, and urodynamics. So in my personal opinion, all pediatric urological urodynamic studies like filling cystometries and voiding pressure flow studies, they should be under fluoroscopic imaging, which is called as video urodynamics. So I would like to emphasize on a couple of prominent pathologies in pediatric urology who might end up with a renal end-stage renal disease. So one of them is posterior urethral valve. So we all know that posterior urethral valves can go through a series of bladder changes throughout their lives. So in order to achieve the maximum results, we need to understand at which phase is the bladder. So we need to do a uroflowmetry, DVSS. Urodynamic assessments are, in this case, a part of the evaluation in our personal practice. So these patients are generally what we use. Generally, we use liberal anticholinergics in order to obtain a degree and normal-like bladder compliance. Also, either double voiding, overnight catheterization, or CIC should also be implemented in order to make the bladder safe for renal transplantation. Another pathology is with VUR, it's vesicular reflux, and it might end up with a renal insufficiency. In some cases, it might go up to 20% of the population with end-stage renal disease. And also in those cases, a VCUG, which is a recent one, should be observed in order to see if there's an ongoing VUR or not. So we all must keep in mind that high-grade VUR is associated with lower urinary tract dysfunction. So if there is still a high-grade VUR, I'm going to talk about it in a minute, we might consider a nephroureterectomy. So these patients are also associated with symptom scores, voiding diaries, or uroflowmetries and post-micturition residual volume assessment. Also, if you need an anatomical assessment like a VCUG, or you are unsure about the bladder habits, so you can go with a urodynamic study, which would show both. In neuropathic bladder, definitely you need to have a video urodynamic assessment in order to see the bladder pressures, at which bladder pressure does the VUR or incontinence starts, and you should be very sure about the patient and the parental compliance on CIC, because if not, you are going to have trouble both lower urinary tract wise and both the medication you are going to give for immunosuppression. So the treatment of neuropathic bladder, of course, we know is consisting of anticholinergic beta-3 agonists. So we need to make a dose optimization before the transplantation according to the video urodynamic assessment. Furthermore, in Europe, we use the botulinum toxin as a second line although it requires repetitive interventions, we are taking into account that these patients might require further assessment. And bladder augmentation is another option that we need to go further with neuropathic bladder. So with botulinum toxin, the patients who are unresponsive to oral drugs, neurogenic disorder activity, phasic contractions, and reduced compliance might be the case that we need to intervene with Botox. But I would like to emphasize that if there is phasic contractions for the neurogenic disorder activity, Botox would work better than a reduced compliance bladder. The mean duration of the effect is 9 months, as you know, and unfortunately, you need to assess the lower urinary tract recurrently with urodynamic studies. And also, we need to take into account that if there are incontinence episodes between the CICs, or if there's a further upper urinary tract deterioration during the course of the disease. So bladder augmentation is another option, which is like we call burning the ships, and there's no turning back. So it's generally done, usually done within the time period that the patient is going on, and like during the course of the disease. And if not, and if you have seen the patient recently and the patient requires renal transplantation, we got to perform the bladder augmentation and wait for 6 months in order to come up with renal transplantation, which might reduce the possible complications during the surgery. So another option is transplanting into vesicostomy or cutaneous ureterostomy. That might be the case in some patients with small ages or some comorbidities that would preclude us to go with bladder augmentation. So this has been shown safe. However, we always keep in mind, we should always keep in mind that if the patient is going to need a continence in some sort of, then we are going to have a problem in an immunosuppressive patient who needs a bladder augmentation. We need to make sure the urethra is integrated before renal transplantation. If the patient is having a recurrent or problematic urethra in sort of stenosis, self-dilation is generally not responsive. So we know that if we ensure that urethra is intact, then we can go. But if not, we need to go for a urethroplasty. A retrograde or VCUH is required to assess the urethra in those cases. And also, we always take into account that bladder might be affected in urethral stenosis or long-term bladder urethral problems. So we need to make sure that bladder is functioning normally. For these cases, we need to make urodynamic studies. My last slide is in some patients we need to do a nephrectomy or a nephrectomy. So not in every patient, we keep the kidneys intact in some of them. However, as I previously mentioned, high-grade VUR and a non-functioning kidney is almost always problematic for the bladder. So we tend to remove those kidneys. In multi-drug resistant hypertension, it's another indication for going for nephrectomy. Although some series have been shown, they are not always as successful as it is anticipated. So in patients with uncontrolled polyuria, that's also another problem. Large polycystic kidneys that you will not be able to implement kidneys in those patients. However, these are generally adult type cystic diseases. In patients with recurrent UTIs, in whom a colonization of the urinary tract might be suspected, we also use our nephrectomy option in those cases in order to get rid of future urinary tract infections. Patients with high stone burdens are also requested to go under nephrectomy, which might be a further cause of squamous cell carcinoma in the future. And also, of course, in patients with higher Williams tumor risk, which are Dönmez-Rasch syndrome, Weger and Beckwith-Wiedemann syndromes, we need to take out the kidneys in those patients. Please keep in mind the timing of the nephrectomy is important, as if you do a bilateral nephrectomy, the patient will be anuric. So the patient will have problems with volume control, which is quite reducing the life quality of life. And although you planned your surgery, you should keep in mind that there might be some unexpected delays, and the patient and the parents' quality of life might be reduced. So you can, if you are going to do a bilateral nephrectomy, start with one side and continue the process at the time of renal transplantation with the ipsilateral kidney. So these are some papers of our EAU, Young Academic Urologists collaboration. If you want to have more further data in these issues, I would suggest you to read it. Just one thing to say: the patients with KCUD, they are prone to urinary tract infections. However, if you have managed the lower urinary tract, the survival, like graft survival rates, are similar to non-KCUD patients. So this is our group, and I would like to invite you to our Congress, which is going to be held next year in Madrid. Thank you very much for your patience.